Hi, everyone, and welcome to this month's Journal Club. I'm Pedro Ramirez. I'm the editor-in-chief of the International Journal of Gynecological Cancer. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recordings will be made publicly available, so participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so we can hear the presentation. And if you're having any difficulties or questions, please send a message in the chat, and our technical support team will hopefully be able to assist you. Definitely, we encourage questions. We will have plenty of time for questions and answer. And if you can, please submit your questions via the chat function. I'll try to read those questions to Dr. Santin, and otherwise, you may also ask yourself those questions that are submitted. So this month's lead article is folate receptor alpha as a successful biomarker in the treatment of low-grade serous ovarian cancer patients using preclinical and clinical models by Alessandro Santin and his group from Yale University, Yale School of Medicine. So I'm very, very pleased again to welcome Dr. Santin. Alessandro, thank you so much, obviously, for taking time out of your incredibly busy schedule to talk to us about this very important and relevant topic. And I want to thank also, obviously, the fellows who have joined to ask the questions, and all of you from around the world who have joined for this journal club. So, Alessandro, once again, thank you, and we give you the floor to proceed with your presentations, and then we'll start with our questions.
Thank you, Pedro. And so I'm honor and pleased to provide you this brief presentation and then start this journal club. So if I can have the next slide. So briefly, let me introduce the topic. Low-grade serous ovarian cancer is a rare 2 to 5% of all epithelial cancer, but has some peculiar characteristic. Is characterized by a inborn resistance to chemotherapy, and this is most likely related to the fact that it's a slow-growing entity, a slow-growing tumor, but relentless in its growth. And because of this characteristic effect, the majority of these patients, similarly to high-grade serous ovarian cancer, are diagnosed with advanced stage disease. Surgery is usually not curative. So we're able to debulk the patient, reduce the disease, optimally debulk the patient, but we need adjuvant treatment. And the problem here, as I just mentioned, is that chemotherapy usually does not work that well. Most of these patients with advanced disease, in some sort of relentless way, they develop resistance and they progress on us. And we don't have very effective tools for this patient. We treat them with aromatase inhibitor because of the high expression of estrogen receptor, and they're usually cytostatic for a significant amount of time. Some of these patients, about 1/3, they harbor KRAS mutation, and those are the patients that are usually more sensitive to MEK inhibitors. But the point is that regardless this tool, most of these patients, they progress on us. So that is why we need to think about the development of new treatment modalities. Last year, we had the Verastem group that was able to get approval for their combination of avutometinib, a MEK inhibitor, and defactinib, that is a focal adhesion kinase inhibitor. But even with this new combination, that is oral combination, only in the KRAS tumor, we were able to see significant activity, a 44 response rate in the RAM 201, while the other 2/3 that are, of course, KRAS wild type, they did not respond that well, 17% response rate. So that is why we need new treatment modalities, and that is what triggered this study. We try to evaluate, as I'm going to show you as a proof of principle, the potential activity of mirvetuximab soravtansine, that is an ADC, an antibody drug conjugate, targeting folic acid receptor alpha in low-grade serous ovarian cancer. So the study was designed in really, as the slide is showing you, in 3 phases. The first one was the tissue validation. So the question was, are low-grade serous ovarian cancer overexpressing folic acid receptor? And that is where Dr. Vittoria Torre in my lab, step in. She reviewed the low-grade serous ovarian cancer patient treated at Yale, where cancer tissue was available from 2010 to 2025. She was able to identify 27 samples with this characteristic. And those were, again, the patient population that we tested in the research component with the folic receptor, for folic receptor alpha expression using a test validated in the Yale pathology department here at Yale. Second step was the validation of the activity of mirvetuximab in a PDX model. We had a patient that was on the Verastem combination that developed small bowel obstruction. So we did surgery. We tried to repristinate patency, and we remove, of course, a few nodules from the abdomen of this patient. We were able to establish an avatar mouse, an avatar tumor in the mouse, and we of course, as a second step, we tried to validate the activity of mirvetuximab in this avatar model. And finally, when the patient eventually progressed on the Verastem combination, and she had already failed chemotherapy, she had already failed aromatase inhibitor, we again treated this patient on a compassionate basis after, again, the patient signing the specific consent with the mirvetuximab ADC. Next slide, please. And these are our results presented in the manuscript. When we look to the expression level, using this research test, we found that 78% of these low-grade serous ovarian cancer, they overexpress at 2+ and 3+ level folic acid receptor, so nice expression. And here I'm showing you a representative immunohistochemistry slide to show you how strong, again, in some of these patients, the expression of folic acid receptor alpha was. In the middle panel, you're going to see the result of our animal model. In this case, we have treated a total of 10 mice, 5 SCID mice with SCID, so severe immunocompromised mice that they were engrafted with this low-grade serous ovarian cancer resistant to chemo, aromatase inhibitor, and MEK-FAK inhibitor. We're treated with either saline control twice a week for 3 weeks, or with the ADC, the mirvetuximab. And as you can see, there was, again, significant activity of the ADC because all animals treated with the saline control, as you can see, in about 24 days, they had to be sacrificed because of the progression of the disease. In contrast, all the 5 animals treated with the mirvetuximab, they were alive at 50 days. That was the cutoff point where we concluded the study, with the disease still under control. And even if we did not show that, we also looked to the weight of this animal as a surrogate of the tolerability of this agent. And again, there was really no significant weight loss in this animal, showing that it was well tolerated. And finally, when we treated this specific patient with mirvetuximab, this patient had carcinomatosis that has caused a bowel obstruction. Here, as you can see, in July 2024, this was our baseline CAT scan. She had multiple area of carcinomatosis. And after starting the mirvetuximab, very rapidly, actually, we saw a decrease in the CA-125 that eventually normalized. And after about 8 months, that this is the last CAT scan that we have available and presented in the manuscript, that was March 2025, the disease was still under control. So I confirmed partial response after 8 months present in the manuscript, I can tell you that the CAT scan of January was also showing stable disease at that level. So still a PR at 1 year. This is a tumor in this patient that was tested with the Ventana test, so the FDA-approved test, and was found to overexpress folic acid receptor at 2 plus and 3 plus in 85% of the tumor cell. Next slide, please. So the conclusion of this report is that mirvetuximab may represent a novel, effective therapeutic option for low-grade serous ovarian carcinoma patient progressing after standard modalities. We were able to show in this pilot work that a large number of low-grade serous ovarian carcinoma patients may overexpress folic acid receptor alpha to the level that may allow them to be treated. I remind the audience that mirvetuximab has been approved a couple of years ago for platinum-resistant ovarian cancer, but is a broad spectrum type of approval, so low-grade ovarian carcinoma patient that can potentially be treated as long as, of course, we are able to demonstrate activity also in this setting. The additional important thing that I'd like to emphasize is that ADC mechanism may bypass some of the inherent chemoresistant mechanism of chemotherapy that are taking place when we are trying to treat low-grade serous ovarian carcinoma patient. In particular, I remind you that this is an ADC, an antibody-drug conjugate, that get internalized through endocytosis when the antibody binds to the folic acid receptor on the surface of the tumor cell, and therefore bypassing, let's say, the multi-drug resistant gene P glycoprotein overexpression that is typical of many ovarian carcinoma patients that develop platinum and paclitaxel. And finally, we were able to demonstrate with the limitation, of course, of one PDX model and one patient, the safety and tolerability of mirvetuximab in this setting. So we believe that with the limitation, once again, of the case report and relatively limited number of samples evaluated for expression, mirvetuximab may represent a novel treatment modalities, and therefore clinical trial are really, I think, warranted to completely evaluate the activity of this ADC in this setting. I believe my last.
Excellent. Thank you, Alessandro. Thank you so much, actually, for having the ingenuity to explore this question in this particular patient population, because I think, until recently, for many, mirvetuximab has only really stood as an option for patients with high-grade serous carcinoma. So to look at low-grade serous and potentially open up more opportunities for these patients is really great and very remarkable work. Very also exciting to hear that it's actually almost 80% expression in low-grade serous carcinomas as well. So we have about 40 participants in the journal club. So very grateful to all of you who have joined the journal club. And again, I mean, obviously, you can turn in your questions through the chat, but we also have questions from our fellows. And first, we're going to go to Milan and the European Institute of Oncology for Lucia Rivero.
Hi, thank you, Dr. Santin, for this promising work. My questions are, given that your study used a non-Ventana and non-FDA approved immunochemistry assay, and considering the prior evidence suggesting that such assay may overestimate folate receptor alpha positivity, could you share your thinking behind this choice? In particular, how do you interpret your findings, given that what we know about the variable performance of alternative antibody clones?
Sure. Thank you for the question. So I remind you, this was a retrospective evaluation, was a fellow project. So the main reason why we could not really use for the research component, the Ventana testing is really related to cost. And so we look and we have used and validated folic acid receptor immunohistochemistry testing available in our facility. And that is, again, the main reason why we did it in that way. Now, in terms of the, let's say, the relatively high, right, overexpression that we found, there could be an overestimation here. We know by previous literature that when you're not using Ventana, you may overestimate a little bit the percentage of positive sample. But regardless, even if this, the true, let's say, overexpression 2+ and 3+ is not 78%, but let's say it's really 15, 20, 30% lower, is still something that I believe, of course, we should consider, because, of course, it may open new opportunity of treatment. And even if the patient population is 50%, I would say that is still, of course, reasonable and must be considered. Finally, again, and this is true for the testing of folic acid receptor that we've done in our work, but is also true for HER2 testing done by thousands of other investigators. The type of antibody they use, the affinity, can make a big difference. The use of tissue microarray, so with small core, 2 millimeter versus the old section, like we did in this case, can make a difference. So there are a lot of potential variables that may explain differences between studies looking to folic acid receptor expression in ovarian cancer and low-grade serous ovarian cancer in particular.
Excellent. Thank you, Lucia, for that question. Now we'll turn over to another site in Italy, Gemelli Hospital, Vincenzo Tarantino.
Thank you.
By the way, you have the choice of asking Dr. Santin in Italian.
That would not be fair for all the other listener. And actually, one of our team is part of this work. Dr. Luca Palmieri was working last year at Yale with Dr. Santin. So first of all, congrats for this article and for all the work you are publishing on ADC with your team. Those are very interesting work. And my question is still about the assay you used for folate receptor alpha evaluation, because you report a 78% positivity for folate receptor alpha. And since, as Lucia said, we know that this non-companion diagnostic assay can overestimate, and of course you said that in your previous answer, how can we exclude that this high positivity truly reflect true biological enrichment rather than an assay-driven overcalling? And how should this affect how we can interpret the results of your study, the observed efficacy signal?
So let me start from the second part. So I don't think that is going to affect the interpretation of the efficacy signal, for the simple reason that the study patient was really tested with the Ventana. So we know that this patient, as I show you in the previous slide, had 85% 2+ and 3+ using the Ventana. And with the patient, we could do that, of course. So that, and also for the PDX model, the same tumor coming from the patient, we know they had that specific expression. And therefore, the efficacy was somehow correlated with the expression as we were expecting, right? It was a tumor with express a very high level folic acid receptor. So again, there are the limitations that I already mentioned. This is a case report, one patient treated. We have a PDX model coming from the same patient, showing in this PDX that the treatment was effective, and we have seen similar result in the patient, and the benefit is still ongoing, as I told you, after 1 year from the time where we started the treatment in this patient. So is this enough? Maybe we're going to discuss it later. No, we need to do for sure a larger study. We need to treat more patients, but I think it's a proof of principle. It's a good start. And remember, this is a tough tumor to deal with, because even if this patient, they survive longer compared to high-grade serous ovarian carcinoma patient in general, they're usually younger, and they really slowly progress on any sort of treatment. So we need to find additional treatment modalities that can be tolerated and effective.
Thank you.
Thank you, Vincenzo. And now we'll turn to Australia, University of Western Australia, Nicole Chris, who, by the way, Alessandro has stayed up until like 3 in the morning to be in this journal club with you. So thank you, Nicole, for still being awake. And please proceed with your question.
Thank you, Dr. Santin, for your work, but also for the hope that you potentially give these patients with rare cancers. My question follows on, and it is related to folate receptor expression, but also to tumor heterogeneity. Other trials in high-grade serous cancer, like the FORWARD-1 trial, failed to show a benefit in primary outcomes of your antibody drug conjugate in high-grade serous cancer, partly due to overestimation of folate receptor expression. If you were designing a prospective trial of this drug in low-grade serous cancer based on these findings, what folate receptor 1 assay would you use? And would you prefer to use samples from the original tumor diagnosis or samples from the recurrent tumor?
So, Nicole, I think that in terms of the sample to use to evaluate folic acid receptor, I would say that I use the primary tumor for the simple reason that I would love to be able to use the recurrent one, but quite often we don't have the luxury to have biopsy in this patient. And therefore we would exclude a large number of patients if we make mandatory the need of a biopsy to really look in only the recurrent setting, the expression of folic acid. So I use the primary. And of course, if the recurrent is available, absolutely fine with that, but I'll not make mandatory in a clinical trial to get the fresh biopsy to do that. Regarding the design of the study, I think that I'll do a phase 2 trial here, probably a Simon two-stage design with a first group of patients, let's say probably 20, 25 valuable, to look to a 3 to 4, right? So I would say a response rate probably in the range of 30%, to consider the study, let's say, positive and move to the second stage. And in terms of eligibility criteria, if we're using mirvetuximab, because that is what we're using here, I would probably use the cutoff that we're using in platinum-resistant high-grade serous ovarian cancer, so 75% 2 plus and 3 plus. You know that there are several other, right, ADC currently in development that seems to be effective, even a lower expression with folic acid. But at this time point, we're talking about mirvetuximab, so I would probably use this cutoff.
Excellent. Thank you so much. Now we'll turn over to Beate Sarta, somewhat along the same lines, Oncology Center in Latvia. Beate?
No, thank you for your work and thank you for your presentation. I wanted to ask, did you have any paired primary recurrence samples from the same patients to assess whether the expression stays stable over time? And for clinical testing, would you recommend using the primary tumor or prioritizing the most recent recurrence when it's available?
If that, if you have a recent recurrent available, like in the patient that I just described, I would for sure evaluate that, because that is the cancer that you're going to treat in your patient, right? So that it makes sense to try to test the most recent biopsy or implant. In term of having tested, right, both the primary as well as the recurrent tumor, we did not have. I don't have those data. As you know, they're rare tumor, and we don't go back in this abdomen quite often, right? Like in high-grade serous ovarian cancer, when they develop recurrence, we usually know that to do a secondary debulking is not easy in this patient. Quite often you damage more. So if you were the patient, pay the price of the brave choice of the surgeon. So that is why we don't have a lot of patients with primary as well as recurrent chemotherapy exposed or resistant tumor available. I can tell you that in our city, we only had one where I had both, and they were both positive at the same level. But for sure, it's one. I cannot really speculate too much.
Excellent. Well, thank you, Beate. And we'll turn back to Gemelli, and we'll turn to Giuseppe. Giuseppe Parisi.
So thank you, Professor Ramirez, and of course, congratulations, Professor Santin, on this really interesting and pioneering work. So my question would be, in cases with borderline or heterogeneous staining of folate receptor alpha, so near cutoff values or patchy distribution or mixed intensity, would be your preferred action to do another test or retest? And if yes, with which assay and with which specimen would you do that? Or to go ahead and treat the patients, or to prioritize an alternative therapy or exam? Thank you.
So I think that if we're talking about treatment outside the clinical trial and the patient has, let's say, a borderline or heterogeneous staining very close to the cutoff, I would say that I'll give the chance to the patient, I would treat the patient. Because as we are discussing, we don't have great alternative in terms of treatment that are for sure effective in this patient. So that is why outside the clinical trial, I would treat the patient, because we have, as you know, years of experience with mirvetuximab. In the majority of patients, is a well-tolerated drug. I don't know if you have questions later on about the toxicity, but as you know, the corneal toxicity, really the common, the most common type of toxicity that we see in this patient is an off-target toxicity that that anyway can be somehow managed in the majority of these patients with the aggressive prophylaxis as well as again ophthalmology evaluation every other cycle to stay on top of it and so on. So I would for sure try to treat the patient.
Excellent. So, Alessandro, we have a question from Albert Jacob in the audience, and he's asking, was there any other marker that correlated with response to mirvetuximab?
We did not really we did not do a correlative study to other biomarker at this time point. It's for sure interesting to look into that. What I can tell you is that we know that TROP2 is also expressed tumor, and we have been able to also show in a PDX model in a parallel study that in this case was sacituzumab govitecan, Trodelvy, was also potentially effective, and because of that, one of my fellow, John Timon Rosario, has submitted to the NRG, GOG, a proposal to the Rare Tumor Committee that has been approved. And most likely, if CTEP and NRG finally approve it, it's going to become a clinical trial in this specific patient population. So there could be additional biomarker targetable with ADC that could be potentially effective to deal with this disease.
Great. And Alessandro, as a follow-up to that, you did mention TROP2. Do you have a percentage as to what percentage of low-grade tumors express TROP2?
Is also very high. I believe is a range of 70 to 80%.
Okay.
Remember, the TROP2, we don't have a specific cutoff like we have for for mirvetuximab, because it's not really clear at this time point. So there is no doubt. This is a as a targeted treatment, you must have the target expressed. But how much of that target must be expressed to see a clinical response in vivo in patient is currently not clear. So,
Okay.
yeah, largely.
So next we'll go to Leila Abulatsi from Tbilisi State Medical University in Georgia.
Hi. So my question is related to the one Beatrice asked. So in your study, nearly 80% of folate receptor positivity was observed predominantly in tissues that were obtained from primary tumors. However, at the time of treatment with mirvetuximab, almost all of these patients will have received systemic therapies, right? And how might these prior therapies, such as chemotherapy, aromatase inhibitors, MEK inhibitors, impact on the levels of folate receptor, and how these treatments can affect on the efficacy of mirvetuximab in heavily pretreated, failed treated patients?
So this is for sure a good question, and it's difficult to answer because, of course, we are limited in terms of clinical experience with the use of mirvetuximab in this specific patient population. What I can tell you is that in the single example that we are discussing, in this heavily pretreated patient, folic acid receptor was highly expressed in this platinum and chemotherapy resistant in general. This patient received, I think, more than 2 years of doxorubicin, so became resistant also to this agent, and was resistant to aromatase inhibitor and resistant to, again, the combination of utometinib and defactinib. Nevertheless, the tumor overexpressed a lot of folic acid receptor, and she responded very well, and she's still currently responded to mirvetuximab. So again, I'm limited to this single example at this time point, but there is no reason for me to believe that previous treatment may dramatically affect the expression of receptor, at least at this time point.
Thank you.
Excellent. So now we'll stay local from Houston Methodist, Alvin Matthews.
Thank you so much, Dr. Santin, for your work on this project. My question is somewhat related to the prior question. It was related to should there be a consideration that prior treatment duration and intensity with other systemic therapies like chemotherapy, aromatase inhibitors, MEK inhibitors may affect the efficacy of mirvetuximab in the setting of progression of disease? And then when we're translating this to clinical practice, should there be any consideration of patient optimization before initiation of this drug?
Yeah, so again, it's difficult to tell if previous treatment may really affect the activity of mirvetuximab in this patient population. For sure, when you're treating heavily, like in the patient that we're discussing, for many years with chemotherapy, this patient, you're going to affect the bone marrow of this patient, and that, of course, could limit your ability and the possibility to treat the patient later on with this type of ADC because of the bone marrow toxicity. So there is for sure, again, this is premature. We only have one patient. We need to show activity in multiple patients. But if that is the case, we should also consider most likely the sequence, right, of this treatment in this patient population. Because if we have an agent that is better tolerated than the standard one-size-fits-all approach of chemotherapy, I think that I would really consider that earlier instead of later. So that is how I can really answer to your question.
All right. So we'll turn now over to Ilker from Turkey, and he's asking an interesting question also about the setting of when to use mirvetuximab. Ilker.
Thank you for this opportunity. It's a great honor for me. And regarding the limited role of conventional platinum-based chemotherapy in low-grade ovarian tumors, how can we apply this folate receptor 1 targeted drugs to first-line adjuvant chemotherapy or neoadjuvant setting?
Yeah, so this is again is a good question. The point is that we don't have the data. We only have really a case report. So more patient treated be really for me to address this question properly. I can speculate a little bit, of course, and if and what I can tell you is that I really believe that in this specific setting, with the poor response that we see in general with standard chemotherapy treatment, I would love to be able to treat this patient earlier with this type of agent because I know that can be tolerated better than the standard combination of chemotherapy that we offer to this patient. But I don't have the data to support that at this time point. We really need to do the study.
Now, we'll turn to Naya Seminario from Vallebrón in Spain.
Right. Thank you very much, Dr. Santin, for your work. I have a couple of questions. I'm going to start with the first one. The first one is that given that the clinical experience of this treatment is now currently limited to one case that you presented, what do you see as the key next steps to translate these findings into routine practice, particularly in terms of patient selection, say standardization for folate receptor 1 testing, and design of trials?
Yeah, thank you for your question. So I would say that in the perfect world, what I would see is the design and implementation and completion of a clinical trial, really to evaluate fully the activity of mirvetuximab in this rare tumor. Is it going to happen? I don't think so. Why? Because as I told you, the drug is already FDA approved for platinum-resistant ovarian cancer. They did not differentiate between high grade and low grade. So that is why it's already available. And I doubt that at this point, AbbVie, that is, as you know, the manufacturer of mirvetuximab, is going to design a study. It could be, but I would be surprised because, again, the drug is available. You may, of course, recommend and prescribe this medication to your patient when they fulfill the criteria of platinum resistant. So that is why, again, I don't think that we're going to do a study on this, or a study is going to be designed. That's it.
So, Alessandro, I was actually also going to add another question with regards to, because this came up in discussion previously in the last week. Your thoughts on actually combination of mirvetuximab and an aromatase inhibitor at the same time, because the patient may say, well, would it hurt?
It's a good question, but it's a little bit a tricky question. And the reason being that, again, we have to really do and try, because aromatase inhibitor, they are not usually a cytotoxic type of drug. They are, cytostatic agent. And as you know, there is some literature in breast cancer showing that the combination of a cytostatic agent such as aromatase inhibitor with chemo could be detrimental, okay? Because you are slowing down even further the metabolism of the cell and making less sensitive to standard chemo. Now, this is not standard chemo. This is mirvetuximab. So the possibility that the combination can have additive or synergistic effect exists, but, we need to try. I cannot really have to speculate.
Yeah. So we have a last question from our fellows, and she unfortunately is not able to join us today. Her name is Anusha Kamath from India. But I believe, Naya, you were going to ask that question?
Yeah, it's okay. Her question was like, unlike high-grade serous patients who have often a shortened duration of the treatment due to the disease tempo, low-grade patients may stay on therapy for a prolonged period. Given the known cumulative ocular toxicities, the keratopathy for this ADC, do you recommend a different monitoring or dose modification schedule for these long-term responders to preserve quality of life?
No, I would say that we have now over 2 years experience, and actually even more because we've done the study. I believe also Pedro, like me, has enrolled patient in the Mirasol study and so on. So this is to say that we have learned that we have to be proactive and, in terms of doing all that we can to decrease let's say, the corneal toxicity and the eye toxicity that is really the commonplace when you're treating patients with this ADC. And we've learned that on the way. And as you know, for mirvetuximab, we are now doing an eye exam baseline in this patient to be sure that they don't have condition that predispose this patient to develop, significant side effect to the treatment. We want to know if she has a cataract already in place, for instance, that is quite common in elderly patient, right, and so on. And the other thing is that you want to start the prophylactic use of the eye drop with prednisone, the day before, and after you continue for a few days after the infusion. So if you were, you have to try to do all that you can to decrease the risk of significant eye toxicity. But I think that the most important thing is really to keep on watching your patient. If the other cycle, look to the eyes. And if you see that the patient reach a grade 2 toxicity, you stop the treatment and you allow the time to the patient to recover. This is the case for this patient. We had to dose reduce her, actually rapidly after the first cycle, more for GI type of toxicity than for eye toxicity, but she eventually developed some corneopathy, and that is why we had to put on all the treatment for a few weeks. Nevertheless, she is still on treatment after 1 year with a good quality of life and with the disease under control.
Excellent. Well, Alessandro, thank you so much. As I promised, I wouldn't keep you more than 45 minutes. I want to thank you for so eloquently articulating those answers to the question. Again, congratulations, really innovative thinking about bringing this drug to this type of disease where we need treatment so desperately. I want to thank all the fellows for their questions, for being present, and all the former fellows. Definitely, always great to see you. We look forward to seeing many of you at ESGO next week. And I invite all of you for the March Journal Club, which will be on our special issue on de-escalation of treatment in gynecologic oncology. So, Alessandro, thank you once again for joining us.
You're very welcome. Thank you all.
All right.